We've talked about why MRI and other vignettes, but I'd like to drill a little bit deeper regarding indications, especially as they relate to surveillance. Now, in other vignettes, you've already heard about the three-tiered system that is used by urologists in Europe and in the United States, and we said patients that are survey candidates are Tier 1 individuals. And who are Tier 1 individuals? People with a PSA of 10 or less, people with a Gleason score of 6 or less, and people with a T category of T1C or T2A, also known as staging categories. We said there may be a subset of individuals in Tier 2 that are candidates for surveillance. So let's talk about indications for surveillance. First, attention is paid to changes in size or stage of the prostate. So if there's a change, for instance, if there's a physical examination in somebody with BPH and the prostate feels substantially bigger to the clinical examining physician, then that might be an indication that the patient should start undergoing surveillance. Now, you might notice that the Gleason score is already up here on the tiers, and one of the indications for surveillance is somebody that's already had a biopsy, because you can't get a Gleason score without a biopsy. So if you had a biopsy, you're in the Tier 1 category, you're a candidate for surveillance. But if there has been any kind of a change in an existing lesion, then you're going to either survey. If it's a big change, then you're going to go in and biopsy. If there's a minor change, you're going to continue surveying. So let's talk a little bit about minor changes for a minute. If there's a change in an existing lesion that you're surveying that perhaps already had some biopsies that were negative or a biopsy that was negative, and that lesion is 3 millimeters in size, it is awfully challenging to detect a change from that lesion to the next interval. You're going to ask, well, what is that interval? We'll get to that in a minute. So in those little tiny lesions, that's a situation when you're surveying where the dynamic contrast enhanced MRI becomes more important, and quantifying the intensity of enhancement and the curve becomes more important. However, for the most part, dynamic contrast enhanced MRI is perhaps the least important aspect of the survey examination, paling in comparison in importance to the T2 diffusion-weighted portion of the MRI and ADC map. Now, another question you're probably asking is, what should be the interval of surveillance? And my answer to you is, it really depends. There is no definable criteria that is published that says you should survey every year or 6 months or 1.5 years like you have with, say, BI-RADS for the breast, where a BI-RADS 3 is going to be 6 months and a BI-RADS 2 would be 1 year. So we haven't come to that point yet, but the decision is going to be based on some common sense and clinical judgment. So the rise in the PSA levels, the PSA density, the result, as we said earlier, of a digital rectal examination, the patient's anxiety. Very anxious patients may want to be screened at shorter intervals, and the initial MR findings. Now, if the lesion was extremely tiny initially, you're not going to get much benefit going back at 3 or 6 months. You're going to have to wait a longer interval in time. Now, what are some inclusion criteria for active surveillance? Well, let's say we've already done a biopsy and we're in Tier 1, because that's how you get your Gleason score right here. You have to have a biopsy. Well, the number of, and remember, when you do a biopsy, it's not just a biopsy. It may be as many as 12 samples in different quadrants of the prostate. So the number of positive results from the transrectal cores may influence you one way or the other. In other words, if it's very few, you'd survey. If it's very many, then you're probably going to be more aggressive and go forward with some type of intervention and maybe even prostatectomy. The percentage of cancer in each core. If it's a very high percentage, you're going to be more aggressive. If it's a lower percentage, that patient is a survey candidate. The Gleason score of the cancer. We already said that we want a Gleason score of 6 or less. The further down the scale you go, the more confident you are. Gleason 2, 3, 4, the more confident you are that surveillance is the right thing to do. The serum PSA levels, are they stable or are they rising very, very slowly, as opposed to a more precipitous rise or a change in the curve? For instance, if the PSA was rising at this level and it starts to go this way, you're going to be more aggressive. But if it stays very linear and consistent, that's a person that's more of a survey candidate. But all those things taken together, if you've got a Gleason score, let's say you've gone back and done a second biopsy, you've been surveying, and you see something that looks like this, or you have some other reason to do a second biopsy, the Gleason score trumps everything. Or if you're tiering a patient and deciding if they're a survey candidate, and this number looks good. Let's say this number was 7, and let's say this number was a T1C, but the Gleason score is 8. The Gleason score trumps everything. Patient is no longer a Tier 1 candidate, and they are going into the more aggressive workup category or the more aggressive treatment category. Let's stop right there, because that's a lot of information for one vignette, and I'm going to let you digest that.